It's because we're going to go briefly over the content. The full paper is available with all references and detailed discussion of how we want to move forward with these research priorities is available on the Maternal Health Task Force website. And I would encourage you to take this little technical summary with you that also refers you to the full paper. So I just want to start with a little context. Unfortunately, HIV and complications of childbearing remain the leading cause of death of women of reproductive age around the world. And in terms of HIV-related maternal mortality, this is really concentrated in Sub-Saharan Africa, which bears the burden of the HIV pandemic. In fact, in 2011, it was estimated that 90% of pregnant women living with HIV resided in Sub-Saharan Africa. And we're learning more about how HIV is impacting on maternal mortality. So a recent study from the London School of Hygiene and Tropical Medicine suggests that a quarter of deaths during pregnancy and the postpartum period are related to HIV, and that women living with HIV are 7 to 8 times more likely to die during pregnancy and the postpartum period than are their HIV negative peers. And this has impacts both on global and regional maternal mortality ratios. So we can see that while rates of maternal deaths have come down dramatically over the past 20 years, in 8 countries in Sub-Saharan Africa with high prevalence, in fact, they've increased. So on this slide, you can appreciate the burden of ill health, disability, and years of life lost because of HIV among women, particularly in Southern Africa. And here the link, the big contribution and the barrier that HIV represents in terms of addressing MDG5 is very clear here when we see slow or no progress, especially in Southern Africa. So consequently, there are very important gains that can be made by improving maternal child health and HIV services for women living with HIV, and that's the intention of this research and evaluation agenda. So it comes out, the process, it began really with a meeting of 56 experts on maternal health and HIV coming together to discuss the evidence base in Boston and research priorities. And after that, I conducted a comprehensive literature review of primarily the peer-reviewed literature, looking at more than 400 papers in order to flesh these out and identify research priorities. And then the paper went through a process of peer review. The conceptual framework for this research and evaluation agenda looks at the problem through the lens of 3 research priorities, or 3 levels. The first is clinical questions about how to best address the main killers of women living with HIV during pregnancy and the postpartum period, and to better understand the interactions between HIV disease and maternal mortality and morbidity, so really at the individual health outcomes of the woman. The second is to look at the health system, and particularly how integration of health service delivery can improve health outcomes for women or not. So we have many questions about that. And finally, the third looks at the broader social context. So how do we create an enabling environment for women, and especially women living with HIV, to begin and remain in HIV and MCH services? And all of this, of course, takes place in the country context, which has different HIV prevalence and also prevalence of other comorbidities that need to be taken into account, but also different levels of development of health information systems and different abilities to actually track and record maternal mortality. And finally, in an overall context, significant investments are being made in strengthening health systems, both for HIV and for maternal health, and to implement treatment scale-up for pregnant and postpartum women, particularly with new treatment guidelines recommending earlier initiation of treatment in all adults, and also promoting option B+, which is immediate lifelong treatment for all pregnant and breastfeeding women. So that provides our context.
afternoon. So I'd like to focus on the first two of the major areas that we thought would be important for moving this agenda forward. And the first is the clinical questions about maternal mortality and HIV. Just push this button. This one? Okay. So these two summary graphs are from a recent systematic review of the literature on maternal mortality and HIV. And this paper reviewed multiple papers and found a pooled relative risk, as Tamil mentioned, of 7.74. And that's where we get this number of the relative risk for maternal mortality among women with HIV is 7 to 8 times that of women without. It should be noted that all of the papers that they reviewed had an increased risk with the exception of one, and that's really quite unusual. To the right is a graph showing the attributable risk, the risk that is attributed to HIV. And the attributable risk increases as the prevalence of HIV in a given country increases. So in West Africa, where the prevalence is around 6%, where the prevalence is around 2%, excuse me, the attributable risk is around 6%. So around 6% of maternal deaths can be attributed to HIV. But in Southern Africa, where prevalences approach 20%, that means more women with HIV are getting pregnant, and those women are at greater risk of dying. The attributable risk is 50% or more, and that is just huge. And that is why Tamil said that unless HIV in pregnant women is addressed, the MDGs will not be achieved, nor will the newer goals of eliminating preventable maternal mortality and the global plan for HIV/AIDS of reducing deaths among pregnant women with HIV by 50%. One other comment perhaps on this. These papers were done basically before the ART era. So that's going to be a question. How is ART going to impact on these mortality rates? So there's two big initial questions. Does pregnancy accelerate HIV progression? And the evidence to date suggests that it does not. Most of the evidence, however, comes from high-resource countries. And there remain questions about whether pregnancy accelerates HIV progression in low-income countries. We know, for instance, that nutritional status can accelerate HIV progression. How does this interact with pregnancy? These are unanswered questions. But generally speaking, the evidence does not support pregnancy accelerating HIV. On the other hand, we do have plenty of evidence that HIV affects maternal morbidity and mortality. We've shown you some of that evidence. And a major question is the impact of ART on maternal morbidity and mortality among women with HIV. So most of the studies done to date have been among women who received ART to prevent mother-to-child transmission, not for their own health. What impact will ART have, particularly option B+, lifelong ART? What impact will that have on maternal morbidity and mortality? We think that is an absolutely critical question to answer. If you talk to experts in high-income countries like the US, they say that this is a non-issue, that there's no increased risk once women are on ART, although there's actually very little solid data to support that. Maternal death ratios are low in high-resource countries, the numbers of deaths are low, so it's not something that people have really looked at. However, the very few preliminary studies from low-resource countries that have been published today do suggest that maternal mortality ratios decrease once women receive ART, that it looks like the risk is dose-dependent, so that the longer women are on ART, the risk comes down further. But there's only one study that's been published where women were on lifelong ART or on ART when they became pregnant, and that study had very few deaths, but concluded that the risk, while reduced, was still elevated. So our first research and evaluation priority for overall maternal mortality and ART includes how does ART, including provision of lifelong treatment, affect rates and causes of maternal morbidity and mortality. More specifically, how does the timing of initiation of ART before or during pregnancy affect maternal morbidity and mortality? And how does the duration of ART treatment affect mortality? And some of our other questions, that's really the key question. And we need evaluation and other types of research to address that. But other questions include, what is the relationship between HIV infections and rates and causes of maternal morbidity and mortality? How does immune status affect complications? We really don't know much about that. And likewise, the question of, does pregnancy influence the progression of HIV disease? So this is actually very difficult to study because of what's known as the healthy pregnancy effect. Women with HIV who become pregnant are healthier than women with HIV who do not become pregnant because the impact of severe disease on fertility. And so it gets really difficult to look for comparison groups. So let's just take a look at some of the cause-specific issues related to maternal mortality and HIV. And most of the mortality for women with HIV is related to infections, related to puerperal sepsis and what we're calling non-pregnancy related infections, such as TB, pneumonia, and malaria. For women with HIV, are 3 times more likely to develop puerperal sepsis, and particularly after C-sections, where the risk increases 6-fold. And we don't really know much about how to prevent that, we do know how to treat it, but we need more information about what types of protocols should be used to prevent it, whether standard protocols for women need to be changed, et cetera. The non-pregnancy related infections are causes of maternal mortality and causes of HIV mortality among all adults. But pregnancy, so HIV increases the risk of mortality from tuberculosis, pneumonia, and malaria, but at the same time, pregnancy increases those same risks. And when you bring the two together, HIV and pregnancy, it doesn't just double the risk. It actually, these two act synergistically to increase the risk many-fold. And Hannah Sebetlone, sitting here on the panel, looked at data from South Africa and found that the risk of non-pregnancy related infection was 30-fold higher among women with HIV than pregnant women who did not have HIV. There's some conflicting studies about the interplay between HIV and hypertensive disorders during pregnancy and obstetric hemorrhage, so the word is still out on those. We need more information. And one of the big questions related to anemia is whether iron supplementation should be provided, because there is some evidence to suggest that iron may stimulate viral replication among women who do not have anemia. So if you have anemia, the iron goes into making red blood cells, but if you don't, there's some evidence to suggest it stimulates the viral replication. So that's a question. Right now, WHO is continues to recommend iron for pregnant women with HIV. So generally speaking, our research and evaluation priorities in this area concern earlier initiation of ART and its impact on the specific causes of maternal morbidity and mortality, questions about the interactions between HIV, ART, pregnancy, and specific complications, questions about how we can prevent and treat women, with maternal complications. Are there particular issues that we need to take into consideration? We know, for instance, with malaria, prophylaxis and treatment, cotrimoxazole seems to be effective, so maybe we should keep women with HIV on cotrimoxazole and not move to SP. And then what treatment regimens are safe and effective? And moving forward, some of the possibilities for studying these questions that we've raised include looking at secondary analyses. There's observational treatment cohorts that are being done in Sub-Saharan Africa, household and community-based surveys, facility-based data, et cetera. So trying to add questions to these secondary analyses related to pregnancy would be one way to answer some of these questions. And we'd like to advocate for indicators related to pregnancy in routine and periodic monitoring, both HIV and MCH, so HIV questions in MCH and MCH questions in the HIV information systems. There's a WHO pregnancy registry that could be useful in looking at HIV and pregnancy. We need improved verbal autopsy tools, nested studies within large-scale intervention studies we think could be very helpful, looking at pregnancy within the larger studies. And new research needs to be done, we think, to really tackle some of the questions. Our second major area is integration and the integrated delivery of health service as a way to improve outcomes for women with HIV. This graph shows results from a systematic review by Ferguson, who pooled data from non-integrated services. And the women who were in this study had to jump through several hoops to get to ART initiation. They had to be tested and counseled. They had to get a CD4 count. This was pre-option B+. And then they had to initiate therapy. And what she found was that by the time you got to ART initiation, only 18% of the eligible women received treatment. And that's a big problem. On the other hand, in Malawi, where an integrated model of care was developed, this is the first country to implement option B+. In option B+, you do not have to do CD4 counts, which simplifies the treatment. And you can see a massive increase in the number of pregnant women initiating ART. This was a 750% increase in 1 year. So that is huge, and certainly is a model that we think will be hopefully will be very successful in other countries. Important areas of focus include integration of ART within antenatal and postpartum care, screening and treatment for malaria and tuberculosis. As I've said, those are major causes of death. Thank you. Postpartum family planning, and a new area of preconception counseling. In systematic reviews, found that generally are finding that by integrating services, the outcomes tend to be positive, although there's questions about balance and costs, but generally speaking, the outcomes are positive on both MCH and HIV. So our questions in these areas include the big broad question of what are the benefits and detriments of integrating services. We'd like to look at quality of care, clinical effectiveness, and coverage. One issue is that many of the studies on integration of services look at process and coverage, but we really want to move to outcomes and what is the actual impact on maternal complications and on maternal mortality. What's the optimal time for delivering each service, uptake, linkages, and retention. Human resources are an important issue when we talk about integration. There's pressure on human services to provide more, one person to provide more services. Can this be done effectively? It seems like it's more efficient to do it that way. It's certainly more efficient for the woman who's coming for services to have one point of care. But how is that going to impact on outcomes? Task shifting is being recommended by many agencies and is being studied, and but we do need more information to ensure that it's having a positive impact. We also want to look at unintended pregnancies and cost effectiveness. I've mentioned that malaria and TB are important causes of maternal mortality, and we do want to look more closely at the coverage of screening for malaria and, well, for TB, and of providing prophylaxis, malaria prophylaxis, to all pregnant women, but including women with HIV and MCH services. And the coverage for these screening and prevention services is still relatively low in many countries and needs to be improved. So the questions raised are about the safety and effectiveness of some of the prevention and treatment being provided. Preconception counseling, we think, is an important area for the future as option B+ rolls out and more women are receiving lifelong ART, viral loads come down, women feel better. There's going to be increasing questions about whether and how to safely become pregnant, and we don't really have answers for that question yet. So we need to look at the efficacy and acceptability of safer conception methods. What are they, and what's feasible in low-resource countries? We also want to look at the mix of models for providing preconception counseling and what happens when knowledge and treatment as prevention, pre-exposure prophylaxis, and preconception counseling become more common, and how does that affect reproductive desires, intentions, and behaviors. And finally, postpartum family planning. The idea of postpartum family planning has been around for a long, long time in MCH circles, but still hasn't been implemented as effectively as we'd like it to, and this is clearly an important issue for women with HIV. So questions again about what are the best models for implementing postpartum family planning, what works, and about dual methods of conception. So again, in general, what we think should be done or can be done to assess and answer these questions are some secondary analyses, looking at retrospective or prospective analyses where integrated services are being implemented. And in fact, there's a lot of work going on in this area right now. But our review was of the peer-reviewed literature, and we didn't really look at the gray literature. So since a lot of this has started in the last couple of years, we don't really have good data about how it's impacting on health and health outcomes. So incorporating research design as implementation, as integrated models of implementing health services are taking place in countries, we think is really important. So do the implementation, but include the design to evaluate what you're doing at the same time. And again, incorporating key pregnancy and postpartum indicators and routine monitoring of relevant programs we think is absolutely critical, as well as perhaps looking at including some HIV and ART treatment status indicators in some of the large-scale surveys like DHS and MICS. And now we move to priority 3.
So I'm going to briefly discuss the third research priority, which focuses on creating an enabling environment for women to begin and remain in care, as well as improving respect for women's rights more broadly and other ways that this can improve women's health. And these graphs, we can appreciate why this is so important, because even though we see that between 2011 and 2012, there's been a huge jump in the proportion of pregnant women who need antiretrovirals for their own health, who are receiving that antiretroviral treatment, there's still a gap between pregnant women and other adults globally, and we're still quite far away from the 80 to 90% of pregnant women who we would want to be receiving antiretroviral treatment for their own health. Further, as you can appreciate in the other graph, there is concern. This is from a meta-analysis of Nachega and colleagues about the drop-off in adherence in the postpartum period. So here you see that only about half of women are adhering adequately to antiretroviral treatment in the postpartum period. And this is certainly of concern, as millions of women will be beginning lifelong antiretroviral treatment. So we need to find ways to support women to take antiretrovirals for their own health, as well as following prevention of mother-to-child transmission of HIV. And of course, there's a whole range of very promising interventions for supporting uptake and retention and care. We've discussed a little bit about integration as a model that increases uptake and retention, as does decentralization of health services, making them more geographically closer and more available. It's also important to look at issues like conditional and unconditional cash transfers and scale up of health insurance as impacting on accessibility. But we in this review to focus on addressing gender and HIV discrimination, promoting rights, and increasing social support for pregnant and postpartum women. So the 4 specific areas that we're looking at is reducing violence against women, because we know that among pregnant women in South Africa, experiencing physical or sexual intimate partner violence was associated with a higher prevalence of HIV, as well as more broadly, intimate partner violence is associated with poor reproductive health and HIV treatment outcomes, as well as being an important women's health issue in and of itself. Second, to engage men in HIV and MCH services. So we know that when men are actively participating and supportive of women's implementation of PMTCT, that outcomes have been better. We know less about how to engage men who are not already choosing to come to antenatal clinics with their female partners in HIV testing and in support for PMTCT. And as we implement these interventions, it's very important to ensure that we are protecting women's confidentiality of their HIV status, their autonomy, and their safety. So it's a very important area, but it also needs to be done with great care. To reduce HIV-related stigma and promote respectful maternity care, because we know that if women anticipate or experience HIV-related stigma or disrespect and abuse in services, they're more likely to avoid healthcare delivery sites or to drop out of care. So an example from Janet Turan's work is that in Kenya, among women being offered prenatal HIV testing, women who anticipated HIV-related stigma from the male partner were twice as likely not to test as women who didn't anticipate that stigma. And finally, to increase community and peer support for pregnant and postpartum women, because it's been shown to increase both the demand for and supply of higher quality PMTCT and maternal health services, and in some cases associated with better maternal health outcomes as well. So for all of these, there are successful interventions, but they have not been evaluated for their impact on maternal health outcomes, specifically maternal mortality and morbidity in high prevalence, HIV prevalence settings. So to give an example of violence reduction, the IMAGE project in South Africa, which combined community-based education around HIV and gender with women's groups that also had a microfinance component, was shown to reduce intimate partner violence by half when compared to the control villages, for example. As far as engaging men in HIV and MCH services, the family-centered care model, or the MTCT plus model, that seeks to engage all family members in HIV treatment if they need it, but in care and support activities. In Ivory Coast, they initiated 95% of the pregnant women who needed it on antiretroviral treatment, and at 2 years follow-up, 98% of those women were still in care. So we have models, and there's some interesting work going on in terms of engaging with men around HIV education and in prenatal care without the need to disclose HIV status, that are showing good results on condom use, on men's support for breastfeeding and other outcomes. Finally, in terms of awareness, action, and monitoring, community monitoring and accountability can generate political will for better service quality, demand for services, and improve health outcomes, in line with the recommendations of the WHO Commission for Information and Accountability for Women and Children's Health, to make accountability and inclusion in terms of accessibility of information available to all stakeholders, as well as the 2012 UN Technical Guidance on Human Rights-Based Approaches to Reducing Maternal Mortality and Morbidity. So the first thing to do is to make sure that taken for granted kinds of everyday abuses are seen as rights violations, and we need policy frameworks that do that, and then to move towards changes in institutional practices and individual behavior through what seems to be most successful from the HIV stigma reduction work is participatory trainings that involve all of the staff that work at a facility and also engage with people living with HIV as trainers and leaders. And finally, in the field of community mobilization, I wanted to mention very impressive results that Prost and her colleagues published in The Lancet in 2013, just before Women Deliver, in which they did a meta-analysis of 7 randomized controlled trials of participatory women's groups. So these women's groups identified maternal health problems in their community, came up with locally feasible plans to address them, implemented those plans, and monitored their results. And across the 7 studies, there was a 37% reduction in maternal mortality where those women's groups were operating as compared to the sites where there were no women's groups. So while this is a disparate evidence base, I think that it's certainly worthy of more research and evaluation. And the main questions that we put forward here is which of these community mobilization, peer support, and male engagement interventions improve maternal health outcomes in high HIV prevalence contexts? Do interventions which reduce violence, HIV-related stigma and discrimination, and disrespect and abuse also reduce morbidity and mortality? So retrospectively, we could, if there was maternal mortality data available for the IMAGE project villages, we could look at that and see what happened with maternal mortality over time. And finally, how do these interventions impact on proximate or mediating outcomes, such as uptake of care, retention in care, adherence, disclosure, and also specifically, do they reduce postpartum depression? I think that there are a lot of questions about women's mental health, receiving an HIV diagnosis during pregnancy, and beginning antiretroviral treatment at the same time, and how is this related to adherence that we need to know a lot more about. So to move the research agenda forward, again, there are opportunities to conduct retrospective, prospective, or ecological analyses in areas where promising interventions have had sufficient coverage. I think it's important to take disrespect and abuse and stigma seriously, including indicators in institutional quality improvement models, to evaluate to what extent community members can participate in data collection with 2 outcomes there. One, because it can increase the frequency at which data about the outcomes of interest is available as compared to population-based surveys, but also on the issue of accountability, it can raise awareness and mobilize communities to engage with maternal health and HIV. And finally, to conduct implementation research. So in conclusion, as both Isabel and I have said, it seems very clear that preventable maternal mortality will not be ended unless we address the synergies between HIV and AIDS and poor maternal health outcomes, and that in order to better address these, we need a better understanding of the interactions between HIV and maternal mortality and morbidity, that health systems need to be further strengthened and integrated, and that we need to move towards a social context that truly respects women's human rights and supports them to begin and remain in HIV and maternal health services. And we also firmly believe that collaborative research and bringing the HIV and maternal health communities closer together in order to conduct this research can both strengthen political constituencies but also communities of practice, and thereby accelerate progress towards goals in both the fields of HIV and maternal health. And I would like to acknowledge the advisory working group, some members of which you're about to hear from as discussants, as well as the external reviewers and the institutions that funded this work.
Thank you so much. A very much deserved round of applause. It was an excellent, excellent overview. I think just to touch on a couple of areas, there was a mention of, I hope you've all heard of it by now, the global plan towards the elimination of new HIV infections among children by 2015. Breath, and keeping their mothers alive. And that second part was quite a fight to get that put in, and it has its own goal, which is to cut HIV-related, and you pulled out many of the causes of that, HIV-related maternal mortality in half by 2015. And that was a very significant thrust in the direction of integrating the work being done in HIV and in maternal health. I think I'd also like to underscore the research agenda that you mentioned, especially around integration of services. There has been a lot of stellar work done already around, like, for example, the Integra initiative in Kenya, Swaziland, and Malawi. There's a UNAIDS, UNFPA program in Southern Africa and with 7 countries. But I love the fact that you pointed out, build in this research agenda as you're implementing the programs, because looking at health outcomes takes time, as we know, so that was excellent. Wonderful, you brought up gender-based violence. It's often neglected. People focus so much on just the clinical aspects of health service delivery, so we know HIV is both a cause and a consequence of gender-based violence. There's now excellent program, very practical guidance that's been issued by WHO and UNAIDS on that. And then lastly, you brought up the family planning factor with family planning 2020, I think, on all of our minds, realizing that 1/3 of maternal mortality can be prevented with family planning. I think that's a very important link. Again, there's very good guidance looking at preventing HIV and unintended pregnancies among women living with HIV. So we do have some work to be done, but there is some guidance there. So without further ado, I want to turn to the discussants. So the first discussant is Hannah Sebit-Luani from South Africa with the University of KwaZulu-Natal. And she has a few slides, correct?
Yes.
We'll just get those set up.
Actually, while we pull it up, I failed to mention earlier, and if you haven't already picked up, if you're interested in tweeting, we're using the hashtag MHDialogue. And for those tuning in, if you do have any questions for the speakers, feel free to ask them via Twitter, and we'll try to incorporate that into our Q&A discussion. Thank you.
Good afternoon, ladies and gentlemen, and thank you so much to the organizers for inviting us just to give you a brief outline of what we are experiencing in Sub-Saharan Africa. I'm coming from South Africa as a country and obviously part of the Sub-Saharan countries. This is where we come from, and many of you will probably have heard about Nelson Mandela, who just passed away. It's my institution, named after him, and privately so. Just for those who might still be having questions as to whether HIV actually is the leading cause of maternal deaths, I think Isabel and Tamil have captured this very well. There is a lot of question about the data and the sources from which this evidence is coming from. From what we know and what we understand is that, yes, it is the leading cause. In many countries, in South Africa in particular, we have a formal way of reporting maternal deaths. It goes through a number of reviewers at an institution. And just for your background, in South Africa, 95% of women access antenatal care. 95% also deliver in institutions, and most of the deaths are captured. We do acknowledge that probably we are only capturing about 90, and I would think the worst case scenario is that we're capturing about 80% of deaths, but the majority of deaths are captured and are analyzed in a formal system. There is a triennial report that is released by the Ministry of Health, and it's called Saving Mothers. You can access it online. and it does take you through the 5 leading causes of maternal deaths. And except for the first report, which was in 2008, every other report after that has indicated that HIV is the leading cause of maternal deaths in Sub-Saharan Africa. But in South Africa, this report comes from South Africa. So we know that it is a leading cause of indirect deaths and also the leading cause when it comes to overall deaths, of maternal deaths. There is a category called non-pregnancy related infections, and Isabel did talk about that. Amongst this, HIV is the major component, and women are particularly dying from TB and meningitis, which are co-infections that go hand in hand with HIV. We also know that HIV is a leading cause because from 2011 and 2012, we have seen a slight decline. I think it's still early days, but we are beginning to see, ever since we started HART or antiretroviral therapy for all pregnant women, there's been about a 19% decrease in the maternal deaths, particularly from HIV-related causes. So in the triennium, the formal report was triennium of 2010, 2008 to 2010. The majority of women were tested. Of the women that were tested, that died, 80% were tested, and of those who tested, about 80% were also positive. So the great problem in our minds is, why are women who are HIV positive likely to die? Not necessarily from HIV, but also likely to die from other causes, and I will show you just now. So in the last report, this was an interim report because the formal one will be released in the latter half of 2014, and it will cover 2011, 2012, and 2013. And why there was an interim report is because there was implementation of HART for all women who are pregnant, and we began to see this 19% reduction that I mentioned. Just looking at this slide, Isabel did tell you that when it comes to non-pregnancy related infections, HIV is almost 30 times, and you can see here that if you are HIV positive, you are more likely to die from non-pregnancy related infections. This is AIDS and all its comorbidities. Just looking at also what the other major causes are. When you look at Sub-Saharan Africa, other causes is obstetric hemorrhage and hypertension. And you can see even for these that do not necessarily have any link with HIV, women are still, if you are HIV positive, you are still far higher, like hemorrhage, than your HIV non-infected counterpart. So the question is, why is HIV women more likely to die? And these are some of the things I'm trying to build up to the question of what research area should we be focusing on? Why is an HIV pregnant woman in the area where HART is now accessed still more likely to die just because she's HIV? You can see the institutional mortality rate for somebody who's HIV infected is about 10 times for somebody who, compared to those who are not HIV infected. So when you look at sources and data from other Sub-Saharan Africa countries, there is direct and indirect deaths. Even amongst the direct deaths, which is obstetric hemorrhage and sepsis, we know that sepsis is related to HIV. When it comes to indirect deaths, HIV is still the leading cause of deaths. Malaria and TB, obviously, which are linked and associated with immune status, are also amongst those, and Isabel has already talked about the issues pertaining to research in this area. So if we go just to seeking solutions and where we should be focusing, the 5 H's, which comes out strongly in our Saving Mothers report that I alluded to. We know that amongst the leading causes of deaths, there's hemorrhage, which applies to all Sub-Saharan African countries. And we know that in hemorrhage, as I showed you, even positive women, being HIV positive, just poses a risk, and we do not yet understand why an HIV positive woman is more likely to die from even obstetric hemorrhage or even hypertension that have absolutely no relationship. So the 5 H's, which is hemorrhage, hypertension, and HIV, obviously. Health worker training, we have mentioned, and the previous speakers have talked about the skills of the women, the confidence of the skills of the health worker, the confidence of the health worker, and sometimes the abuse that the health worker is giving, and some of the speakers will talk about that. So there is ongoing training in terms of emergencies in obstetrics, staffing issues where women are really overburdened as well, and also just trying to educate the health workers about the ethics and the human rights, which many times are eroded when people are understaffed and such. The other issue is strengthening the healthcare institution. We find from leadership, which is hospital managers or CEOs of hospitals, they need to be integrated into understanding what maternal mortality issues are, and they need to be roped in. They need to understand that sometimes not providing the basic infrastructure such as medicines and adequate staffing, how that translates into the overall failure of a country to meet the MDGs. So we need to improve all of those, as I mentioned, including staffing. There's also other initiatives that the countries are embarking on. One is called KAMA, which is Campaign Against Accelerated Reduction of Maternal in Africa, maternal deaths in Africa. And they've gone quite a long way in trying to get policy and politicians to be able to buy into the initiatives, to be able to get into a political will and community mobilization, also improve the health delivery platform, things like trying to improve maternal health facilities, such as waiting mothers areas for women who stay in the far-flung areas, or sometimes accessing things like maternity, dedicated maternity ambulances and things like that. So that has been done. So just on, as a summary, we need to get forward to trying to document exact causes. As Isabel did say, we are not sure at this stage. We know that HIV is contributing in a significant, if not direct way as it is. Improved data collection, and this should be ongoing. It may be in terms of autopsies, and some countries have already begun to do autopsies, which may be verbal, but even clinical autopsies to be able to establish the exact cause. We need best models to avail these preventative therapies, anemia, for example, TB. Already we know that INH preventative therapy does reduce maternal deaths, and it can be used even up to 36 months, as a study did show in Botswana. Things like malaria, we know that if you are coming from an endemic area in Sub-Saharan Africa, most women are actually immune. But what happens during pregnancy? Does that immunity go away? Why do women still die from malaria in those areas? Sepsis, as Isabel has already said, do we need to give antibiotics to all women who are HIV positive? If so, what are the gains in terms of resistance? What are the losses and things like that? There are biological associations. We know that if you are HIV positive, you are likely, or actually AIDS, women tend to deliver prematurely. So we don't know, is it the diseases, is it the infectious diseases in the lower genital tract, or is it just the disease process itself? We also need to understand, it has been said, as Isabel said, that we think we know that HIV does not progress during pregnancy, but most of these studies were done in developed countries. We really need to get back to, why do women actually succumb? If not during pregnancy, 60% of the deaths do occur postpartum. So these biological associations are not yet clear, and we need to get back to that. We also have seen that there is some relationship between obstetric hemorrhage, hypertension, and some studies in South Africa have been done to see, is there an increase? Because from a theoretical point of view, hypertension may be reduced in somebody who's HIV or on heart. South Africa said no, 2 studies that I'm aware of. But in Botswana, there was a study that said, yes, there is an association. So those type of things need to be continue to be followed up so that we can get a clear understanding. As well as obstetric hemorrhage, women who die are mainly HIV positive, and they may be dying from obstetric hemorrhage, which has nothing to, is it the drugs? Is it the endometritis that may be underlying? We are not sure. We also need to pay attention to reporting of adverse event, particularly from the drugs. Isabel did mention the safer drugs to use in pregnancy. We did see a rise in the maternal deaths in 2011 when all women accessed HAART, and it's because our HAART contained nevirapine, and that nevirapine led to a lot of liver toxicities and such. And fortunately, we were able to pick it up quickly, and the regimen had to be changed. So things like that, which are uncommon in Africa, need to continue to be part and parcel of ongoing research. Integration of individual interventions into user-friendly packages. I want to stress the term user-friendly. It's very well good for us to say integrated packages and all of that we need to put in prevention of anemia, prevention of malaria. But at the cold phase, when you've got a health worker who's short-staffed and she has to remember, I must give iron, I must give calcium, I must give IPT, I must do this. At the end of the day, that's where the link breaks, and that's where an overwhelmed system with all its good intentions will not achieve what it is. So we need to package it in such a way that even the health worker is not overburdened, is not over psychologically pressed, to say, I must deliver on this and deliver on that. So all of those things are important. And as I said, women are continuing to die. Majority of them are HIV infected. We are not sure why. Is it the immune system failing? We need more research. I don't think the chapter is closed on this issue. As I said, most studies were done in developed countries, and we need studies that will compare women who are on treatment and those who are not on treatment, because there are still countries who are giving just single-dose nevirapine or even just AZT and not necessarily full heart. So we still have opportunities to do those comparisons before everybody gets onto option B plus, as Isabel did say. Is it the drugs? I did mention that sometimes we don't know whether this hemorrhages, is it due to the drugs or not? Limited interventions, are we doing enough? Just giving INH prophylaxis, malaria prophylaxis, is this sufficient to prevent maternal mortality from HIV? Or is it the healthcare giver? Somebody did mention the abuse of women that may prevent women from accessing. We do know in South Africa that women do come for care. 95% do come for care, but they still die. So we need to find out, where are we missing it? Where is the breakage in the whole system? And I believe that we can do this with audits, as the previous speakers have mentioned. Thank you. I'm sorry if I took too much time.
Thank you. That was excellent. You can't say it was too much time when you made such excellent points. So thank you very much. And I just want to throw out the possibility of platelet dysfunction in there in terms of a possible connection with hemorrhage and HIV. Okay, it's probably the only thing you didn't mention. Anyway, thanks. Okay, so we have two more discussants. The next is Heather Watts from OGAC.
I don't have any slides, which is kind of new for me because I was at NIH for a long time and I always had like twice as many slides as I should have had. So I'll try to remember everything I'm supposed to say here. I appreciate this opportunity to be here. Obviously, PEPFAR has a strong interest in the health and survival of HIV-infected women, as outlined, as mentioned in the global plan. It's not only elimination of new HIV infections in children, but it's keeping the moms alive. And one of the best ways to keep the children alive is to keep the moms alive and have them healthier to begin with. So the first step in that, obviously, is women knowing their status. And PEPFAR has supported testing for over 12.8 million women in the past year for HIV to identify those who are HIV infected, and then has supported over the past 2 years provision of antiretrovirals for about 1.5 million HIV infected women. And the good news is that access to regimens that are going to improve mom's health has increased from 34% in 2009 to 65% in 2012. So we're not just providing single-dose nevirapine or AZT over the course of pregnancy. We're talking about B+, which will hopefully improve mom's health and reduce the mortality rate. As noted, the global plan advocates stronger links between programs for HIV treatment, maternal health, child health, and family planning. We've been working with country teams, governments, and implementing partners to integrate HIV care and antiretroviral treatment into the MCH setting and to integrate family planning. We're providing additional resources for integration activities to facilitate B+ rollout in target countries. There's been development of a B+ monitoring and evaluation framework, which any day now should get released, which will help look at how we're doing with integration, evaluating that, evaluating things. Talk about that a little more in a minute. Recently there have been targeted resources to 5 countries directed specifically at integration of family planning into MCH and HIV settings. The country teams had to develop a plan for what they were going to do, how they were going to do it, and then how they were going to evaluate it. Also, the gender program at PEPFAR, there's a gender technical working group, which is looking at gender-based violence prevention and mitigation, and they have a lot of programs in many countries directed at that. Another thing that PEPFAR supports is the Saving Mothers Giving Life project, and I hope many of you were probably at the event last Thursday where the results of phase 1 of Saving Mothers Giving Life were released. This is a public-private partnership between the U.S. government, obviously, Merck for Mothers, the Norwegian government, the American College of Obstetricians and Gynecologists, Every Mother Counts, Project Cure, and then obviously the governments of Uganda and Zambia, where it's taking place. It builds on the history of PEPFAR building infrastructure for prevention of maternal-child transmission, human resources for health, supply chain management, blood safety, and strategic information systems. And it builds on this to integrate better training for emergency obstetric services, demand creation, and the results, for those who weren't at the event last week, the maternal mortality in there are 4 districts in Uganda, 4 districts in Zambia where this was piloted. The maternal mortality decreased 30% in Uganda and 35% in the Zambia districts in the first year of this program. They were aiming for 50%, but I think a third is a pretty good reduction over a 1-year period. They also saw an increase in facility deliveries, 62% increase in Uganda, 33% increase in Zambia. There was an increase in antiretroviral coverage for the mothers and the infants. Going forward, PEPFAR will continue to support these activities. There's going to be expansion in both Zambia and Uganda to additional districts, and we'll continue to support some of the activities, including demand creation, to try to increase facility deliveries and antenatal care, transportation support, human resources for health, training, equipment, supply chain management, monitoring and evaluation, which especially in Zambia included an evaluation of causes of maternal death, and tuberculosis screening and prophylaxis. There's also an expenditure analysis piece to the SMGL phase 1, so that it's looking at what did this cost, and it actually ends up being somewhere on the order of $6 to $12 per birth to implement these programs and show this market reduction. And some of those costs are probably a bit higher, again, with the intense monitoring that was built into the initial program. So we'll continue to support the expansion. There's hope for expansion to additional countries, but that hasn't been definitively worked out. Going forward, PEPFAR will continue its greater than $300 million annual investment in PMT-CT programs that also strengthen maternal child health platforms and provide access to ART for the HIV-infected women, which hopefully will impact mortality. Again, I mentioned expansion of the SMGL activities. There's the monitoring and evaluation framework I mentioned. It does include monitoring of TB screening, diagnosis, and treatment for pregnant and breastfeeding women in the antenatal, obviously postpartum setting, as part of the routine monitoring that has been added. So hopefully with this being looked at, it will actually be done at a better rate. There also include enhanced monitoring at some sites, possible sub-studies of maternal mortality, nutritional assessments, rates of family planning, counseling, screening and treatment for STIs, and retention through 36 months on treatment, both for the mother and then for the infant. Also recently, those of you in the research realm may have noticed the program announcement 14024. That's an NIH PEPFAR collaboration for implementation science supplements. The idea with this is that these are existing grants, and if they're in areas, there's a whole list of obviously topics we're interested in, but one of those topics is determining effects of implementation of BB+ on maternal mortality in HIV-infected women, and those allow for 1 year of funding for projects directed at whatever the specific questions in the grant were, but expanding the focus of those grants. And then we will have some targeted funding available to PEPFAR country teams to evaluate what are the best methods for implementation of B and B+ and follow-up of women and children. And these can include evaluation of maternal health and mortality with expanded antiretroviral availability. So we are definitely aware of this issue and very interested in it, and always looking for more opportunities to support the health of women.
Thank you so much. Again, you touched on many, many points. I'll just underscore, you have mentioned the mother-baby pair, which is extremely important to understand that their health is very connected, and mother survival does have implications for the child's survival as well. The option B plus rollout, especially through integrated service delivery, this is something that PEPFAR is strongly supporting. There was a meeting, I urge you to all go online and look for the report of it, which is coming soon, with 13 countries last year in October, looking at integrated service delivery and how that would benefit the complete rollout for the global plan. And of course, you've underscored the work around family planning that now PEPFAR is very involved in, including through the support to these 5 countries, who I never remember the list of them on the top of my head.
Remember 4 for sure.
Okay, that's a good start. And then, of course, supply chain management you brought up, which hasn't yet been mentioned, but we can discuss that soon. So now for the last, but certainly not least, discussant. Here is Florence with ICW.
Good afternoon. First of all, thank you for having us here, and thank you for making it possible for women living with HIV to be present in this meeting. I think we do not take it for granted. Inclusion is something that we take very dear. I'm ideally supposed to discuss how do we create an enabling environment for women living with HIV to be able to, uptake MNC services and commodities, and basically have retention to care and adherence to ART, some of the things that are really important to their health outcomes and those of their children. Women living with HIV, especially from Africa, where I come from, are constantly in fear of losing the status quo of their life, family, friends, relatives, but most importantly, the support they get from their male partners or husbands. So disclosure is still a big issue. And the fact that having to go out and get treatment or go to the hospital and be tested at an ANC clinic and be told you're HIV positive means you have to go back and bring your partner, and then you have to come back with him, or bring someone to the clinic and they have to be told you're HIV positive. You do not know what that means. And you do not know if then going back home, you still have a home to go to. And some of these things have made women shy away from coming to the clinic. So many women come to the clinic when they're pregnant, but do not come back again, especially for women who are told or whose results for HIV are positive. So issues around stigma and discrimination, issues around gender-based violence from partners and from intimate partners or husbands is still something that needs to be addressed. And I think if not, then we will continue to have women who shy away from delivery at the health center. In my country, we report about 95% of women attend the first antenatal care facility. But by the time we have deliveries, we only have 42% of those women coming to deliver at the health facility. Most women shy away and want to deliver at home. So when asked why this happens, most of them, it's because they are fearful of the HIV results. Some don't even go back for the results. Some do go back for the results, but by the time you go and get your CD4 test done, you're told to wait another extra month for the results. In that 1 month, you are not so sure whether you're supposed to start treatment or you're not supposed to start treatment. So for some of these women, that is enough time for them to change their minds about going back to the clinic altogether. So we have lost to follow up of those women as such. Another issue is basically, maybe aside from the structure, is the geographical access. Most of the people are living away from the health facilities, especially those people that are in rural centers. So you have to walk miles and take various modes of transport to get to the health facility. And you walk in there and you probably get one, service, and you have to come back for another service, and you have to tend to, your animals or your farms and stuff. So many of them will not come back because they feel this is not working for them. So ideally, maybe addressing this through mobile clinics or decentralizing the services to the most nearest possible point where these women can access this care without having to walk the many miles or go very far to access some of these services. Uh, Supportive networks are very good. As a member of ICW, International Community of Women Living with HIV, who I represent today, and as an employee and member of the National Empowerment Network of People Living with HIV from my country, where I work, we see a lot of help that come from the fact that people living with HIV can sit together and discuss some of the issues that affect them. You're not alone. You walk out of that test room and you're confused and you don't know what to do. But when you sit somewhere as a group of people and you realize you're not alone, that in itself is huge. I don't know how we can document that, but it is huge. And some ways of documenting it is probably through qualitative research. And I believe that then people living with HIV need to be involved in documenting qualitative research, because then it may not be the numbers, but it actually brings out the voices and what people, and especially women, indicate as their challenges and why exactly they do not access or they do not have, they do not adhere to medication or do not get to the hospital in time. So supportive networks have assisted in educating. Through support groups, women are educated on the need for adherence and why they need to take their children for vaccination and why they need to do the PCR tests. And of course, questions around, there's always something new in research coming up that we cannot even keep up with. Do we breastfeed? Do we not breastfeed? What is safe? What is not safe? And so when we sit together in those support groups, then we are able to have someone with the knowledge and who can be able to explain to us. It is something different from what we get from the health facility, maybe because of the human resource strain in the health facilities. You may not get a doctor unless you're probably in a private institution explaining some of these things to detail. So you're told, don't breastfeed, and nobody tells you why. Take your medicines at this time and nobody tells you why. But then moving this to a support group then breaks it down. This is what the medicine does. This is why you need to take it. This is why you need to give your child, the septrins at this time and at this time. And so then the woman begins to understand it, and then they are able then to own it. So this happens well when women are integrated into support groups. What I have seen also work very well in my country, and I think is emulated in Uganda as well, is the Mentor Mother program, which we have with support from Mothers to Mothers, where we have a select group of HIV positive women identified. So when a woman is positive, then they are directed to a room where they meet a woman who's equally HIV positive. So it's that thing where, okay, so you can feel me. So I would probably listen to you other than listen to a doctor tell me something and go like, you have no idea what it is I'm going through. So those women are then tracked. And this works, in partnership with the Mothers to Mothers, the Mentor Mothers, and we have in my country people we call the Prevention with Positive facilitators, who are recruited in support by so many of the people I've seen, the organizations represented here. But the Prevention with Positive facilitators then are able to track these women at their homes, just to give them support throughout their pregnancy and to ensure that then they're able to go to the hospital, deliver in the hospital, and probably follow them up. But then again, this is not in all the sites that probably we would want to see. It's mostly, again, in near to reach areas, but in hard to reach areas, I guess the resources are not available. Psychosocial support is important for victims of gender-based violence, but moving forward, it's just about how then do we ensure that the structural environment from which they come from is responsive enough. Because if I have an intimate partner who has, been violent to me, and I am told, you don't need to bring this up for the sake of the family, and I have to shut up and things like that. So I don't know where to go. So women need to be encouraged to know where to go. I think sometime last year, ICW with support from ICW East Africa with support from ICW Global did some research to just try and see how women are benefiting from the PMTCT program. And I think there was a question on that research document on how how do you feel? I think it was more of a how do you feel? You were served. Was it good? So there was good, not good, and stuff. And I think most of the women answered, I would not know what to compare it to. So because we don't know what to compare it to, whatever it is we get, we just take it, you know. So, so maybe trying to make the women become more aware of what is their rights, what then isn't. And when I go to the health facility, this is how I need to be treated. This is how I need to, the nurse or the doctor shouldn't tell me this, or this is how, you know, confidentiality needs to be maintained. I do not need to be tested unless I give consent, because those are legal, within our legal instruments. When women understand some of these things, then it becomes easy for them to then seek recourse when they feel that they have been wronged. For example, again, in doing research with support from ICW and other partners, we were able to discover that there was a number of women, and I think 5 years back, that underwent forceful sterilization because they were HIV positive, and the nurses and the healthcare workers at the time didn't feel they needed to have babies. Most of these women didn't even know this was wrong. So addressing the issue then, moving forward, was, so we educate the healthcare workers, and then we educate the community, but the women themselves now then become empowered. Encouraging male involvement is key. I like to say that you can talk to a woman all you want, but to an African woman, she goes back to a man. So if you leave the man out of this, you're just wasting your time. He makes the decision somehow. So you have to find a way to involve men. And I am beginning to see a lot of male involvement practices coming up. We have in pilot in my country, the Mentor Father program, where we have HIV positive fathers, you know, talking to their fellow fathers about how they need to support women, and especially pregnant women. But moving forward, again, just involving the community at large, because Africa is, and I think my country is, mostly affected by traditional issues, religious issues, and socio-cultural issues that we need to probably have to start explaining, even if it's through gatekeepers like opinion leaders, why we need to drop some of these things so that then women are able to access the healthcare they need, especially women when they're pregnant, and how this affects positive health outcomes for them and their children. So in conclusion, I was to discuss what ICW has done around ensuring that women uptake and are retained in care. And some of the things have been to support women to understand that it is not wrong to want to be in relationships. HIV has been, 30 years? HIV and AIDS has lived, I think, 30 years or so. And we've seen transitions, and now we do not, I don't even think I represent the face of a person living with HIV 20 years ago. People are different now. Medication has made people look better. So then you woke up and you can, you know, take care of your dreams. There are children who are born HIV positive. I believe they also have their dreams and they have things they want to do. And some of them affect their sexual reproductive health. So how do we begin to address their needs to have a partner, to have relations, to have children? So some of that is to begin to make women living with HIV not feel like it is something wrong, to want to explore those needs, but they need to do this with the direction of their healthcare provider or someone who can be able to advise them or give them support to make informed choices so that they do not infect someone else, they do not infect their children in the process. We have seen a world becoming a bit more tolerant, where we have many more discordant couples, where one partner is positive and one isn't. So how do we then ensure that the positive person does not infect the HIV negative person? ICW supports projects to promote hospital delivery, antenatal attendance, and breastfeeding for women, giving information, supporting support groups to ensure that the women are tracked if they are pregnant, and something that is has been mentioned by my discussants before me and is very key right now, the pre-conception counseling. So that it has also been noted that when women are talked to before they actually get pregnant, they become better at adhering to medication. They understand better what the outcomes are, as compared to they just walked to the antenatal clinic and then they are pregnant and then they have to start medication. And I think this is important even as we are going towards option B+, which we are completely advocating for, to educate women. I come from a country where I think only 22% of the pregnancy has been documented are planned for. So it means majority of the pregnancy are mistimed or not wanted. So this leads to abortions and issues around women finding out their HIV status when they are pregnant and not because they planned. So preconception planning, counseling is also very important, and it makes women prepare, and I think it has made women adhere better to information. Use of other ways aside from, the contemporary support groups. We have, again, statistically, Africa has many people with cell phones and they are 3G enabled. So using technology, thank God, to try and reach as many women as possible and the communities where they come from with the information they need. Because then it's easier to get the information you need without having to come out and disclose your status. And this makes it easy for women to come out and access this information, and especially around, and I think right now there's so much questions around breastfeeding, what is right, what is wrong, mixed feeding, how safe am I if I take my medication, so that women then are able to understand some of these things. Okay. So support research, I think for advocacy to work, we need to move towards, just in conclusion, having research that supports advocacy. People living with HIV can be very, very important in ensuring that we have the qualitative data that we need to support advocacy. We can have all the science, and I think the science is right. But if the science is right and we still have the deaths and we still have the infections, then we need to probably sit down and have people living with HIV involved in finding out exactly what is going on. Why are we not adhering to medication? What are these bottlenecks that we face? Is it in our communities? Is it in our workplaces? Where is it that the problem lies? Is it at the healthcare facility? So then we are able to address it from that angle, because then if you're able to bring the social context into the science and merge this, then it would make it possible for people living with HIV to have an enabling environment for them to be able to access the care they need. Thank you very much.
Thank you very much. You've really raised many, many issues. We're going to move into the discussion period now. I think just to some of the areas you touched on, looking at qualitative research and the importance of that. Again, I think there are some good tools out there now. One is the Stigma Index for people living with HIV. I hope all of you have heard of that. If not, Google that when this session finishes. You mentioned the mentor fathers, similar to like a fathers to father, mother to mother program. Questions around whether or not this is going to continue to be unpaid work for so many people, and how feasible is that, and how right is that. The research that you mentioned that ICW and GNP Plus have been doing around women's experiences in accessing integrated services around EMTCT and B+, the area of B+, will be published soon. I actually have it in my inbox to review, so that's on its way. Look for that. It'll also address forced sterilization and abortion. And of course, you brought up the issues of adolescents, some of whom have been HIV positive since birth. Again, excellent guidance. One document that comes to mind is Happy, Healthy, and Hot, which is an IPPF document which looks at how to support some of those concerns. And again, you brought up preconception counseling, particularly important also around issues not only of safer pregnancy, but also for serodiscordant couples around prevention issues. So with that, I think we have enough issues to fill in the 30 minutes. So who would like to start? I don't know names, I'm sorry, and I also, even if I know you, I can't see with these lights, so who will be bold and start things off? Oh, okay, gentleman in the back.
Thanks for this presentation.
Yeah, I think you're going to have to use a mic so that, thank you.
You could turn the lights up.
And if you want to direct your question or have it open-ended, however you want to do it.
Well, thanks for the presentations. A lot to think about. I'm Jim Ricca from MCHIP project from the Maternal Child Health Integrated Program. I just had a really quick question, I hope. Dr. Hanna, I think maybe would be directed at you. That 49% figure as one of, we're talking about the attributable mortality to HIV. 49% in particular was mentioned for South Africa. What does that include? Is that only the part that, I don't know, that is from HIV itself, or are we counting the increased risk from other direct and indirect causes of maternal mortality?
Thanks. I think we're going to take a few questions. It'll give the panelists a chance to ponder how they're going to tackle their response. So next.
Hello, my name is Eunice Kimunai. I'm from Kenya. I wrote my dissertation on this very topic of mother-to-child HIV transmission. And we all know that some of the guidelines, for example, the guidelines that is most of the providers follow when they're educating their patients about breastfeeding, for example. They tell them, exclusive breastfeeding for 6 months. And widely practiced in Africa, for example, is really very few women exclusively breastfeed for 6 months. So the question that I have, I don't know who's going to answer this question, is how do these guidelines, coming up with these guidelines, do we consider cultural practices so that it's very easy for the providers to educate their patients and also for the patients to adhere to these guidelines?
Thank you. Another question? Yeah, I can't see who has the mic. Yeah, do you want to just, yeah, perfect. Thank you.
Hi, thank you so much for this presentation. It was excellent. I'm Melissa Scher from JSI, and I really appreciated Florence's last talks about how she kind of unpacked the third piece of the agenda in the first presentation, the more social context and structural issues that are related. One of the things that she mentioned was the qualitative issue, and I just wondered when you were doing this research, what qualitative research questions you were coming up with, and where are some areas where we could dig deeper into those issues related to specifically social context, but the other areas as well.
Thank you. Let's take one more and then give a round of responses. Can you, yes, thank you.
Thank you. Those were really great presentations. I'm Janet Turan from the University of Alabama at Birmingham. And I just wanted to think a little bit about the integration, service integration, and just wondering, just maybe a caution that maybe it's not a panacea. Sometimes we seem to think that if we integrate these clinical services, then all the problems are going to go away. But we have done a cluster randomized trial of ANC and ART integration in Kenya, conducted by UCSF and Kenya Medical Research Institute, where we found that integration was getting more women enrolled in HIV care, great, getting more women on HAART earlier, great, but we did not have better adherence and retention, and actually, at least we only had a 1-year follow-up. We were not able to see differences in maternal and infant outcomes. And this has been presented at major international conferences, and we're working on getting it through the review process to get it published, and it was supported by CDC PEPFAR. But I just wanted to say that, we need to think, integration may not be enough if we don't address these social and structural issues as well.
Excellent. We're going to pause there and we'll give the panelists a chance to respond. So we have one question, a specific one for Hannah on the 49% figure, what's included. Do you want to start with that?
Yes. Thanks for the question. I think just as a background, just to understand, going back to Isabel's slide where she showed that the maternal mortality increases as the seroprevalence in a country increases. In South Africa, we have 1 in 3 women being HIV positive. This is the antenatal seroprevalence survey. So 30% background HIV risk. So these are pregnant women. Now, this 49% is the proportion of non-pregnancy related infections, conditions, or indirect causes In that is included HIV and its comorbidities, which accounts for 40%, and the other 8.8% is from surgical and medical disorders such as appendicitis, whatever, but mainly cardiac disease. So we have a large proportion, which we can clearly say about 40% is HIV related. Now, if you look at, again, the other evidence that I showed, that of the mothers that died, in the last 2 years that were included in the interim report, 96% were tested. Most women are tested, by the way, but 96% of the ones that died were tested and 90% were positive. So apart from just the 40% that we know is attributable directly to HIV, we've got a large number, 90% of people who die are actually HIV positive, not necessarily directly due to HIV, but that's the question that I posed. Why are women who die mainly HIV infected? Even the conditions that are direct somehow seem to be worse off in a patient in a pregnant woman who's HIV infected. I think that clarifies. And just moving on to the second question, I'm sorry, somebody talked about exclusive breastfeeding in Africa. If we remember, these guidelines came in the days of Sub-Saharan Africa, where there was no antiretroviral therapy. There was a study, and this exclusive breastfeeding came from my institution as well, Ana Custodis, and they showed that it is safer for a woman to do exclusive breastfeeding than to do mixed feeding. But we need, some of the guidelines have been passed on over the generations. It's almost like how to use AZT for 6 weeks postpartum from the 1994 076 trial, and they've never been updated over the years, even in the evidence of more effective antiretroviral therapy. Today, women are taking heart when they breastfeed. Babies are under the cover of nevirapine when they are being breastfed. So we need to actually go back and question the science. Do we still continue to promote this exclusive breastfeeding where it is actually very difficult to implement?
Thank you. Just the gentleman who asked the first question about the 49%, are you okay with that, the response? No further follow-up? Yeah, okay, head nod, that's good. All right, so now the floor is open to the panelists for the other questions. The one I think in general about how do we come up with these guidelines and guidance documents. I think I mentioned at least a half a dozen during my commentary. And how relevant are they and what do they take into account? A question on qualitative questions, especially addressing the social context, and then something on service integration and what some of the other components are to make it work.
So perhaps, do I touch it? No.
There might be.
So kind of to bring together the question about exclusive breastfeeding and qualitative research and the points that Florence brought up about what is the information that is provided to women living with HIV about their own treatment and care and the protocols necessary for their children. If I was to look at this from a qualitative perspective, I'd want to understand first what are the barriers and what do women actually understand about exclusive breastfeeding. So do they understand the rationale for exclusive breastfeeding? And what are the barriers to them doing so? And also, Ana Koutsoudis is currently undertaking research on peer support in order to support exclusive breastfeeding among women living with HIV. So I think that there's more to be learned. More broadly, on the qualitative research question, I think that there's lots to be asked around adherence, as well as preconception counseling, particularly that we know very little about what people living with HIV and what providers know about treatment as prevention, about how to more safely conceive, about pre-exposure prophylaxis, about emerging research. So there are questions there both to be answered qualitatively for people living with HIV and providers, as well as policymakers about what they think is feasible. And certainly around the experience of integrated services, because that's going to be key for whether women remain in integrated services and adhere or not. So those would be some of the key points that I think we need to look at qualitatively in this research and evaluation agenda.
Thank you. Do you want to go next, Isabella?
To thank Janet. Is it on? to thank Janet for her comment about the fact that integration is not a panacea. That is a very important comment to make. We did try to say that you do have to look at outcomes, so it is very interesting and sad in a way that although adhesion or initiation increased, that long-term adherence did not, and that outcomes were no different. But I would also say, as you sort of alluded, that 1 year of follow-up is not enough, and the duration of treatment is going to be key. But those are really important issues that you raised, and we need more studies like that to help us, to guide us with respect to what we really need to do to improve outcomes. So thank you.
Yeah, two comments. One to the guidelines, and this is based more on my experience with the U.S. perinatal guidelines rather than WHO, but writing guidelines is always a balance between what the science says and what you want to recommend, because a lot of times there's just areas where there's not enough data, or you have to go based on the data. I mean, I was in the trenches with 076, and I don't think most of those moms gave 6 weeks of AZT to their kids. Some of them did, but you know, it worked. So we have to at least explain to them what we know works and go from there and hope that they at least do enough of it to do that. And we do include women living with HIV and also women, you know, people working in the trenches, so to speak, on those guideline development groups to try to get that perspective and say, okay, you know, here's what the data say. What do we think this really means, and you know, what can we recommend? So again, we try not to go beyond the science and the guidelines, understanding that a lot of times when we are writing these, that people aren't really going to do exactly what we're recommending. As far as the integration, I think I would see that as a necessary but not sufficient condition, because certainly when you go out, if you know, some clinics transitioning women, this was recently in Uganda, at 6 weeks postpartum into the HIV clinic. So now they have to go to the HIV clinic for themselves. If they want family planning, probably have to come back to their MCH clinic, and then they have to bring their kids into immunization. And in the HIV clinic, they've got all these people with TB and stuff coughing all over their newborns, right? So, you know, that's not a good setup. So integration is necessary, and the more things, and Uganda is working on a recommendation to keep the moms and the babies in MCH through 18 months postpartum, cessation of breastfeeding, and final diagnosis for the infant, and that makes a lot of sense. But I agree, we can't necessarily think that that's going to be the end-all and be-all. We still have to work on peer mothers and family support groups so that the whole family can come for their clinic on that day and the dad can get treatment too, because again, we run into problems where the moms can get ART in MCH at maybe a health center too, but because they're not really ART clinics, the dad has to still, if he gets diagnosed, has to go, you know, to another place. And what's he going to do? He's going to try to probably borrow the mom's drugs, right? So, I mean, I think again that it's probably necessary but not sufficient, and that's one of our focuses now going forward, is how to best integrate, but also add on these other services to promote adherence and retention, so that we are continuing to follow the moms and the infants, and so that they're actually taking their drugs.
I'm going to make a comment now or wait for the next round. Okay, so we have time for another round of questions. Okay, I'm trying to be fair here. So let's go 1, 2, 3.
I'll try to be quick. I have two comments on a question. One on the breastfeeding guidance. I think one of the key things about the new guidance is supposed to be now that the guidance is the same for everybody. The exclusive breastfeeding issue in 6 months came long before HIV and ART and whether they took drugs or not. And so the point is that the guidance for infant feeding is the same for everybody essentially now, regardless of whether you're HIV. And the more we focus on that, I think it takes away the stigma. If you're HIV infected, you have to do something different than everybody else. And I think that we've been so focused on infant feeding for HIV infected women that we forget that infant feeding guidance for women is essentially the same now. Secondly, I think the integration issue is really key, because integrating services in Rwanda, for example, we talk about it's a great example of integration, and they're integrated in the same place, but they're not always integrated in the same day or time. So it's the same clinic, but mothers come on one day and babies come on another day, and immunizations is a third day. And so it's completely integrated, but it's actually for a woman, it's not integrated. So what does integration mean is really critical in these definitions. And then my question, though, is on the research agenda, one of the challenges that we looked at, you mentioned that these sort of proximal indicators and then looking at true outcomes, much of the time that requires longer follow-up. And so much of the system is set up, and even some of the RFAs and the Implementation Science Awards are so short that you can't get to those outcomes. So in the funding world, organizations that do it, somehow being able to figure out how to have longer follow-up to assess outcomes it would be much easier to get those data if there was a mechanism to do it. And so everything is cut short because it takes so long to get the study up and IRB running and doing it, and you have 1 year study. We stop because of the funding mechanism. So being creative about how to fund these things to look at further outcomes would be really key to answering some of these questions. Oh, sorry, I forgot to say who I am. Laura Gay from the Elizabeth Glaser Pediatric AIDS Foundation. Sorry.
Hi, Ronnie Lovich, also from the Elizabeth Glaser Pediatric AIDS Foundation. I have a question for Tamo and Isabella. I'm from the literature reviews and the meta-analyses that you looked at. Is anybody looking at trends with age disaggregation? You know, we sometimes have trouble connecting our priorities, and just reflecting on the huge portions of global plan countries where you've got girls in marriage or union. There are probably some important trends that we just need to be aware of, because I'm suspecting that there's probably important differences if we had the opportunity to really see what some of those age and maybe parity differences are.
Thanks. We have, yes.
Thank you for this. I'm Caroline Odada from Kenya, but living in America for now, in Pennsylvania. On behalf of ICW, I'm just curious about the HIV and maternal health, maternal child and morbidity and mortality, and the question marks that are there. Have we really dug more into what could be causing this? Because it's actually an open question. We see it, it's an open secret. We know it's there, we know they're dying, but have we really done enough research on what could be causing the deaths of the women who are living with HIV? Why are they more vulnerable than the other women? And I'm talking about this because in a community setup, and I'm from Kenya, I've lived and brought up in Kenya, and I've known this. I see there's a lot of lack of laboratory monitoring in most cases. There's situation of women being started on ARVs without even the CD4 count. So I think it's not something that we should just leave as mysterious. It's something we can work on. It's more of a comment. And then to Tamil, I can't agree more with the research and implementation. Yes, to the community, but after the research and community implementation, do we go back to the same community and avail the results to them? Because with this, actually, the community will be part of your research, and they'll be able to be part of you in all the programs. Or global plan, the beautiful global plan. We talk of keeping the women healthy, but the truth is, when we implement global plan, most of the strength, most of the money, and most of all that comes with global plan goes to the child. We are more endeared to the child than the mother. And when I talk about that, we should talk about malaria. It's a killer disease. The HIV positive woman who lives in the Sub-Saharan Africa is likely to die of malaria than HIV-related issues. We are talking about the cervical cancer. Do we ever get to, most of the time when women die of cervical cancer or any other cancer, they actually come to know about it when they're in the last stages and nothing can be done about it. And we are talking about TB and integration. When you talk about TB integration, Of course, we are having the teething problems, and that is in Kenya, in respective to Kenya. But look at the integration that we have in Kenya. We are actually having TB clinics just next to the antenatal clinics. And most of the time, when we have this, we have the TB, the woman being realizing that they have TB, it's when they're already breastfeeding. And chances of passing TB to the child is even more. And I'm talking from experience. This is not anything as we are really getting into integration, as we are advocating for integration, let's see what works for the community, what does not work for the community. And all this, you could put all the structures, but when there's no nutrition, when the woman is poorly fed, nothing can really work. We know how good nutrition comes with HIV. So most of these question marks that we leave could even be not anything medical. Most of the question marks that we cannot answer in these researches could be thus something that is socio-cultural.
Thank you so much. Thank you very much. Okay, we're supposed to wrap up by 2 o'clock.
We had one more back here if you want.
That's right. If you could make it very succinct or figure out a way to rephrase it for the next half. It's your choice.
Well, thank you very much. It's going to be very succinct. Emmanuel Pepper, I'm from the National Institutes of Child Health and Human Development, National Institutes of Health. So basically, I think Dr. Watts had mentioned this, but I wanted to piggyback on this. Basically, could you elaborate on how you did your meta-analysis? I know there's tons and tons of literature on HIV, but I know a couple of speakers also mentioned that some of the reports were actually from countries that were non-low middle income countries. So I would like to get an idea of how you came up with your recommendations and what were the criteria you used to sort of put this together. Thank you.
Thank you. Okay, we have 3 minutes, and a lot I think was commentary, which is good, but if you can very, very quickly, like in under a minute, try to respond to what you think is left responding to, and the ones you couldn't get at, there will be a break between 2 and 2:10, and you can follow up.
So I just want to thank everybody for their comments. Very interesting and a lot of food for thought for us just from the comments. But let me, there's one, respond to the question about trends with age disaggregation and parity. That's a very specific question. So the problem is, as with maternal mortality data in general, as I think we both mentioned, there isn't a lot of data. And the world is using estimates, using modeling to try and figure out what maternal mortality is in many countries. So there really is very limited data on age and age disaggregation and parity, and certainly very little in the literature. But I think that you're right, that this is something we have to look at, and the whole issue of adolescence. Now we're getting into prevention of HIV and working on that in antenatal clinics, which I also think is extremely important. So
thank you. And Tamil?
I can respond to the question about how we did this. So this was a comprehensive, not a systematic literature review, and we developed the research and evaluation procedures through this process of consultation with experts and also looking at the literature and the questions that were remaining there. So we did not do a formal process of grading the evidence and doing a meta-analysis. That's not what we're presenting here. So that's a bit about process. And I just want to emphasize, because I think that's what the question was rather than to Dr. Watts. So if I'm not, we can talk over the coffee break.
Perfect.
If that's not the response. And just how important it is, and I tried to underline that in my presentation, to engage in community-based participatory research, but also accountability mechanisms, and to take that very seriously in the delivery of health systems. I think that that is what's going to take us the final mile towards really improving quality.
Thank you. Anyone else from the panel? We've got 1 minute remaining. Yes.
And just really quickly, I want to respond to the research issue, and I think I gave sort of a quick overview of sort of PEPFAR's take, and I think that we mustn't forget there's like NIH that funds for 5 years. They did just recently have a BB plus RFA looking at maternal and infant effects. We may or may not be co-funding. I think PEPFAR does fund research on multiple levels, helps sometimes co-fund networks and projects. There are some PMTCT 2-year programs, but I'm constantly reminded, having come from 15 years at NIH and being a very big fan of research, that every dollar that we spend on research, we're not spending on treatment for somebody, either an adult, a child, or a pregnant woman, and other PEPFAR services. So we're constantly trying to balance what money we want to put in research, how we can use the data. We certainly take in all the data that we can get from whatever source, but we're constantly balancing. So we're trying to integrate the latest research findings and then provide short-term, ways to get answers quickly where we feel there's a need to inform our agenda. So we are cognizant of that.
Thank you so much. Just a big round of applause for yourselves and for the panelists. And good luck for MDG. The MDGs, we're almost there, and post-2015.